Thanks, Supersonic, for this kind invitation. I have to admit first that I feel a little bit out of my element here because I'm a hepatologist by training, so I just collaterally focus on ultrasound and liver elastography, while all of you are probably experienced radiologists, so don't shoot on the piano player, which is me. So nowadays, most ultrasound vendors have elastography software in their devices, but only a few have proven clinical applicability. You have heard certainly of transelastography, FibroScan, which was the first method. Then elastography was implemented in conventional B-mode imaging, and eventually ShearWave Elastography was developed as a two-dimensional real-time method. Now, I won't bother you with terrible details about physics and mathematics. I don't know myself either. I think that as operators, we just need to know that in liver elastography, a single beam of ultrasound creates shear waves, which can then be translated in tissue stiffness values, meter per second or kilopascal. The uniqueness of real-time ShearWave elastography is that multiple US beams are created in order to generate a real-time elastogram, which actually looks like this in the liver. If it works. Does it work? No, it doesn't work. Well, anyway, it should, you should see a blue blue imaging, blue code. And so, well, I'll just go further. What I suggest in my personal experience is that you have to take 3 or 4 minutes of your time in order to find the proper space between the ribs to eliminate all the air artifacts and then to stand very still with the probe in order to have a proper acquisition. And if after that, if you ensure this, you will have your measurements in really less than a minute. So these here are examples of last week's hepatology clinic. You see blue is soft, and while the color shifts gently over the red, the tissue, the liver, becomes harder and harder and therefore fibrotic. In the last picture here, you see also a little bit of ascites, and this is just to point out that ShearWave elastography works also in some condition where others elastography devices are impaired. Now, if we look on the PubMed, you see a great amount of papers that have been published on the ShearWave elastography. But if we narrow our search strategy to the pediatric setting, you see that there are clearly fewer studies available. Nevertheless, I think that we can already draw some important conclusions, so we have an overview about these studies. First of all, when evaluating a new technique, we have to assess for feasibility and normal values in healthy children. So I've looked through all the literature and I've found that more than 350 healthy children were evaluated by ShearWave elastography, and the mean values reported are usually around 5 or 6 kilopascal. There is one single study reporting a normal value of 7 kilopascal, but in my opinion, this is a little bit too high. The success rate was always 100%, and I won't go into detail, but also in the pathological conditions, the success rate is always high, up above 90 or 95%. Moreover, there were no significant influences given on the stiffness measurements given by age, sex, location of the measurements, or respiratory status of the patients. And this study here, Sheehan and colleagues, 2016, they also tried to assess for the intravariability, reproducibility. So they took 3, 5, 7, 15 measurements on the same subject, and they concluded that there was a perfect overlapping of the measurements. So you can just go with 3 measurements in children. But why can ShearWave elastography be helpful in chronic liver diseases, both pediatric and adult? We have to bear in mind that correct staging is crucial to establish a prognosis, to prioritize for treatment, and also for potential reversibility of liver disease. So can we correctly stage liver fibrosis in children with liver disease? Probably yes, according to this preliminary data. We have 4 studies that used as a reference under liver biopsy, or in one case fibroscan, in a population of children with mixed etiologies of chronic liver disease. And you can see that we always have very good or even excellent values of sensitivity and specificity in assessing the whole spectrum of fibrosis, so F1, F2, F3, or even cirrhosis. There's one studies with less satisfying results, but in this case we have the number of patients included was really too low, so 24 patients, so a major limit for this study. Let's move now to a specific type of liver disease, very prevalent, non-alcoholic hepatitis. Pediatric obesity is a major epidemic in our Western countries, and it is extremely important to distinguish children with simple steatosis from those who have NASH and associated liver fibrosis, because the latter are at higher risk of developing progressive liver disease. So we had our group study which involved a large cohort for pediatric standards of 69 children with biopsy-proven NASH, and this was done in collaboration with a pediatric hospital, the Bambino Gesù Hospital in Rome, which is a major pediatric referral center for all kinds of pediatric liver diseases in Italy, well, actually, Vatican City. And the first conclusion is that the failure rate was very, very low. That means that in a population with a mean body mass index of around 30, we could achieve all the results in all the children, except in this single chubby kid with a body mass index of 40, so where also simple ultrasound is challenging. Secondly, we performed ShearWave measurements with 2 operators in a subset of patients, and we showed that there was an excellent inter-observer reproducibility, so intra-class correlation of 0.95, so perfect overlapping between 2 operators on the same subject. And we then generated ROC curves to establish the diagnostic accuracy of ShearWave elastography in this kind of patient. And as you see, if we choose a cutoff value of 5.1, we can exclude the presence of any degree of liver fibrosis with a very good area under the curve value of 0.92. While if we try to establish the diagnosis of significant fibrosis, which is a clinical very relevant information, we see that the area under the curve is even higher, 0.97, by choosing this cutoff value of 6.7. The sensitivity values are 87% and the specificity 96% in this case. So this is very encouraging data because it resembles what has been shown so far in adult patients with NASH. As fibrosis progresses, portal hypertension occurs, and portal hypertension is a marker of prognosis and disease severity that is very important for us hepatologists. Now, this study from Korea tried to correlate ShearWave measurements with 33 HVPG measurements in a population of children with various types of liver diseases. And you see that by choosing a cutoff value of 18.4 kilopascal, they could efficiently rule in or rule out the presence of clinically significant portal hypertension, that means above 10 millimeters of mercury, with high values of sensitivity and specificity, and an excellent value of area under the curve of 0.91. So you have the chance here to avoid invasive procedures like portal vein catheterization in these children. Let's move to another pediatric disease, biliary atresia, which is a progressive sclerosing inflammatory cholangiopathy that usually develops within the first weeks and that progresses rapidly to biliary cirrhosis and has a poor outcome if left untreated. Now, a major challenge is to try to establish an early diagnosis. So these 2 studies from China evaluated more than 200 children with suspected biliary atresia, and you see that by choosing these cutoff values around 9 or 10 in the second study, we get very good / excellent area under the curves of 0.79 or 0.99. So here again, ShearWave elastography might be helpful to distinguish between common and temporary cholestatic syndromes of newborns in comparison to a serious condition such biliary atresia. Finally, there is another interesting feature of ShearWave elastography, which is very promising in my opinion. You see here a hyperechoic lesion in a 9-year-old boy, could be everything. A CT scan in the arterial phase that show hypodense lesions. And finally, if you do the ShearWave elastography on lesion, you see very high stiffness values, 125 kilopascal. And this was a case of neuroblastoma metastasis. And this picture is taken from this work where the authors try to discriminate hepatic angiomas from malignant tumors in 20 children. And you see there are fairly good area under the curve values of 0.77. So you can have information to distinguish between benign and malignant lesions in children. And another important thing, the reproducibility was also fairly good, 0.81 the intraclass coefficient between two operators. And this is important because I think that ShearWave elastography in focal lesion is a little bit more trickier than the normal elastography of liver parenchyma. So to sum up, we can say that ShearWave elastography is able to combine standard B-mode imaging and real-time elastography, and this is quite important for us operators, clinicians, or radiologists because we get the chance to have more information during a single session of ultrasound. It is a novel technique that is highly feasible and highly reproducible in both the normal and pathological conditions of pediatric diseases. It has a very good diagnostic accuracy in the non-invasive assessment of liver fibrosis, especially in the pediatric NASH setting, but also for other forms of pediatric diseases. And for the future, we are waiting for more confirmatory data and also the ability of studies that will assess the use of ShearWave elastography in the monitoring of progression of chronic liver diseases or in predicting occurrence of relevant clinical events. Thank you.